Hello and welcome to the General Pediatric Playbook. Let's go into the evaluation and management of pits, tags, and cysts in the newborn. You will quite commonly see this in your general pediatric practice. So here's the first case, a full-term 3-day-old female, unremarkable birth history, feeding well and down 6% from birth weight, not jaundiced. On physical exam, you have a right-sided preauricular skin tag and the location denoted here and normal ear anatomy. Second case, 2-month-old female, unremarkable birth history, presents for well visit. The parents noted a raised bump under the skin of the baby's right eyebrow in this location right over here. Physical exam, you have a hard, compressible, sub-centimeter subcutaneous, non-movable nodular lesion on the outer aspect of the right eyebrow, and it does not transilluminate. This will very commonly happen. So what is this? What's the diagnosis? And what is the management? Let's go into the quiz. What is the origin of tags, accessory tragus, and preauricular pits? Are they dangerous? The answer is they are not dangerous. They are just embryologic remnants. Are renal ultrasounds recommended? And when might they be? So this is a fallacy that everybody thinks when you see these embryologic anomalies that you have to do a renal ultrasound. That is absolutely not the case. Only if you have a structural abnormality with the ear like microtia, or you suspect something like Bohr syndrome, which is broncho-otorenal syndrome, autosomal dominant syndrome. On prenatal ultrasound, you'll likely see some sort of renal hypoplasia. It comes with bronchial cleft cysts and ear abnormalities. So if you see something that's suspicious of a syndrome or craniofacial abnormality, then you might do a renal ultrasound. Otherwise, if it's an isolated anomaly, you do not. Is a precautionary hearing evaluation required for these ear anomalies? And the answer is no. The newborn hearing evaluation is sufficient. Unless there's a family history of hearing loss, and again, if the child looks syndromic in some way, if you see craniofacial abnormalities, then you would repeat the hearing evaluation. Otherwise, do not. The newborn hearing is sufficient. Where are dermoid cysts usually located? So dermoid cysts, like we saw in the second case, usually located on the eyebrow, the neck, or the scalp. They're along what are called embryologic fusion planes, which are basically the seams where two structures come together to form the face. You distinguish it from occipital nodes. So a very common location is the back of the head there. You can get dermoid cysts there, and they can seem like occipital nodes. The difference is nodes tend to be soft, they're bilateral, and they're mobile, as opposed to dermoid cysts, which are fixed and they're hard and usually singular. One thing to note, these midline cysts, if you get a midline cyst, commonly along the sagittal suture, sometimes along the lambdoid suture, but midline in particular, those require MRI because there might be intracranial extension. All right, so here is our evaluation and management algorithm for pit, cysts, and tags. So with the anomaly, so if you have a tag or an accessory tragus clinically, generally no symptoms. The evaluation and management, you do not repeat hearing. You do not do a renal ultrasound unless, again, you have some sort of craniofacial abnormality. If the ear itself is abnormal, you suspect something syndromic, then you might do a hearing or renal ultrasound. Otherwise, it's just something cosmetic, and you would do elective excision. Preauricular pits, same thing. Generally asymptomatic, however, they can have sebum drainage, and occasionally they become super infected. And the management, again, you don't have to do hearing. The newborn hearing is sufficient. You don't have to do a renal ultrasound unless there is concern for microtia, syndromic, craniofacial abnormalities, and elective. Again, this is an elective decision versus waiting for an infection and then excising it. Dermoid cysts, generally well circumcised. Remember, they're along those embryologic fusion planes. The most common locations, eyebrow, the neck, and the scalp. Generally, they are asymptomatic. They can become super infected. This is a clinical diagnosis. Remember that you are going to image the midline ones because they could have intracranial spread. If you're uncertain if it's a node or a dermoid cyst, you're not certain what it is, then you do an ultrasound. And these things generally have to be resected because they can become super infected. They can erode into bone. They can become things like meningitis, osteomyelitis. So you're going to send this kid to a pediatric surgeon somewhere between 6 and 12 months if you think it's a dermoid cyst. Okay, we never skip the basic science integration. Let's go through the newborn hearing assessment. So what is the pathway of sound? Here we have a nice picture on the bottom. In the outer part of the ear, you have the conductive hearing, right? So from the outer ear to the middle ear, and the middle ear, so that's this space right here. The middle ear is comprised of the tympanic membrane, the 3 ossicles, and the oval window, right? And then and that comprises conductive hearing. And then you have sensory neural and auditory neuropathy, or the auditory neural pathway, and that goes from the cochlea to the cranial nerve number 8 to the brainstem to the auditory cortex. So you essentially have three components of hearing: conductive, sensory neural, and auditory, the auditory component, the neural component. So what type of hearing screening do we do in newborns and why? So we do what's called otoacoustic emissions, which basically that's where you put that thing into the ear. It sends sounds to the cochlea. So it skips the conductive part and goes right to the cochlea. So you're not testing conductive hearing, you're testing sensory neural hearing. You get a lot of false positives, meaning that newborns fail this test all the time, usually because they have vernix there, so the sound doesn't actually make it to the cochlea. You just repeat it when they get out of the newborn nursery. And the reason we do that as opposed to ABR is because it's cheaper. What is ABR? That's called auditory brainstem response. That actually requires electrodes. It's a lot harder to perform. And basically what that tests is sound propagation along the nerve, so cranial nerve 8 and the brainstem. So you're testing the auditory neural pathway. So that, again, skips the conductive pathway of hearing. Real quickly, nobody uses this anymore, but I'd like to review the Weber Rinne. Remember, that's the tuning fork there located on the right side of your screen. Nobody uses it, but in Higuru, we like to remind you of the basics of physical exam. All right, so how would you use this? So the Weber is where you would hit and you get the vibration of the tuning fork. You put it in the middle of the forehead and you see if sound lateralizes, right? So that's number one. Number two, if it lateralizes, then you perform what's called the Rinne. The Rinne is where, again, you hit the tuning fork, you get a vibration in the stem, and you place it on the mastoid process in the back, right? And generally, air transmission is greater than bone transmission. So you wait for bone transmission to extinguish. The person doesn't feel it. And when they don't feel it, you hold it up to the ear. Hold it up to the ear, and air conduction should be better than bone conduction. If it's not, that's a conductive hearing issue. So if the Weber lateralizes to one side, you do the Rinne. And the Rinne is positive, meaning that bone conduction is greater than air conduction, then you have conductive hearing problem on that side. If, however, conductive hearing is normal, right, so air conduction is greater than bone conduction on that side, then you have a contralateral sensory neural hearing loss. That's the Weber and Rinne. All right, thanks so much. Remember that I always use a great review article, Considerations of the Management of Congenital Cranial Dermoid Cysts. You can always get the evaluation and management algorithm added to your desk so that you have quick reference when you're actually caring for patients. That's on my Substack. And coming soon, I will have an entire comprehensive general pediatrics playbook course. And of course, feedback, comments, write me at pediatrics@iguru.com. Thanks so much.